Welcome, everyone. Thank you for your interest in joining the GIS core breakout session. Hello, Tom. Hello, Prasad. Just a couple of things before we get started. If you can, would you please keep your microphone muted? Please type any questions that you might have in the chat box, and we will either, depending on time, get to those questions at the end of the speaker session, or there's going to be a 10-minute window at the end. I did put in the chat, hopefully everyone can see the order of who's going to be presenting and what time specifically, so that if you're trying to come in and out with others, you're welcome to do that. This will be recorded and available on Whova, so if you miss any talks, you are welcome to come and view them later. And then just a quick plug, we just opened up the 2022 GIS Scholars Program. So that's a $4,500 scholarship for any graduate student or post-grad doctoral trainee. So if you know someone that could be interested, please send them our way. The information will be available on the Big Health Data Science Center website. And before we get started with these talks, I wanted to just kind of give you a little introduction to what our view is and how we've changed from the past couple of years. I took over from the great Jen Eberth last year, and I really had this vision to grow our GIS core beyond the School of Public Health and Geography. And so we were so fortunate to be able to bring in Dr. Diego Leal from sociology, who does some really amazing, interesting work on migrant movement. We brought in Dr. Brian Love from the College of Pharmacy, who does neat work on, vaccinations and other kind of pharmacy related work, which he'll talk about today. And then we have Dr. Corey Schnell, who we brought in from criminology and criminal justice, who's really interested in looking at how crime is impacting health in urban areas. And then we were very fortunate to also continue having Dr. Susan Wang from the College of Geography, who is one of the leading experts on remote sensing. I've enjoyed getting to collaborate with her. And then Dr. Xinlong Li, who is another one of those just really formidable experts in the field of GIS. So fortunate to have us as a big team. So when we envisioned what this breakout session could be, we thought, it's virtual. We're all getting tired of these long talks. So we thought we would just give you really short and sweet introductions into some of the work that we do and how we use GIS. I think when we, kind of conceptualize GIS, we all consider making maps, but it's so much more than that. And we each have been able to incorporate it in our own unique ways. So with that, again, we'll have 15-minute talks with each person. And I guess I will get started. Well, we have a few more minutes. We'll get started at 1:20 with my talk. So we do have a couple minutes before we get started. If anyone from the audience that joined wants to introduce themselves, you're welcome to do it. I believe you can speak and share video like you normally would on a Zoom call in the breakout session. Okay, shy folks today. Well, do any of the other core members want to say anything? All right, shy speakers too.
I'll introduce
Thank you for the
myself.
introduction. That's great.
Thanks everyone for coming. I'm looking forward to this session. Thanks, Melissa.
Hi, Miranda. Sorry I'm late.
No problem. Happy to have you, Nathan.
Hi, Melissa. Hi.
Hey, just to let you know, in the chat box, we put whose everyone's time is, so you'll know when you're going. Okay, and if you guys don't mind, I'm the first speaker, so I will go ahead and get started. Again, please don't forget you can put any questions you might have in the chat box and we'll answer them as time allows. Okay, can everyone see my screen? Looks good. Okay, awesome. So I wanted to talk to you guys today about how I've been able to integrate GIS into some of the research that I've done, and I think somewhat of a novel and unusual perspective. So we're all familiar with mosquito-borne diseases. We've all been bitten by them in these pesky, Columbia summers. But just to give you a broader context, when we think about malaria, there's 219 million cases annually that are diagnosed with malaria. We have 96 million cases of dengue every year. And so we're thinking about 300 million cases annually from mosquito-borne diseases in comparison to less than 2 million cases of breast cancer diagnosed every year. So mosquito-borne diseases really are truly a global burden. And in a recent article that we just published, we did a policy looking at how reactive we are in our healthcare system. This isn't just unique to the US, but as you can see from this graph here, we're reactive in our funding, which means that most mosquito control agencies never know if they're going to have a big budget, a small budget, and there's huge fluctuations. So in the times when it's really lean, they have to stretch and use their resources in a very limited capacity, but still trying to manage that excellence of what people are used to. And so we thought of kind of the concept of, can we use remote sensing to streamline mosquito control? So can we do a better job of identifying where we should be spraying chemicals or where we should be doing different public health initiatives and efforts using these techniques? And the concept of this was first kind of approached in 2006. A colleague of mine, Nicole Atchie from Notre Dame, did a study in Belize and identified that there was a decent amount of accuracy. So they could predict 76% of the mosquito breeding areas along a river to then go and respond to Anopheles mosquitoes. And I'm sure you're thinking, wait. What is remote sensing? I came in for a GIS talk. I don't know what this is. And so I thought I would give you just a very basic overview of it. So remote sensing is based on the concepts from physics. So we know that as light waves travel and they hit something, three things can happen. They can either scatter out, they can be absorbed by that material, or they can reflect off. And so we utilize that reflection as a way to give us meaningful information that we can use for analysis. So as you see on the top right-hand corner, different types of vegetative stress or different environmental conditions are associated with different wavelengths, basically meaning that I know an oak tree leaf gives off a very specific wavelength range in comparison to daffodils or dandelions. And so we can then use and pull out these different pieces. We can also create pulling out the different images and putting them together in indices to give us meaningful information. So for example, if you've ever taken a selfie on your iPhone, if you go through and click on the different kind of filters that you can apply, so you have the monochromatic, you have the black and white, you have, you know, the one where it's really bright blue and oranges, it will identify different features. So for example, my cheekbones are really pronounced in a black and white, but not so much in some of those high, you know, more colorful ones. And so we can use similar concepts. Another thing that I like about remote sensing is that we can take something that's an abstract image or photograph. So for example, this is a satellite picture of Harris County, which is Houston, Texas. I can take what's just a very pretty picture and I can turn it into meaningful data that I can use. So essentially we create land use or land classification categories. So I take that satellite image and then I say, this is a forest, this is a water area. And so you take that picture and you turn it into 15 or 40 different categories, whatever you want it to be, that then gives you data and continuous variables you can analyze. This has been really very well developed from the Department of Defense. So during World War II, when we started the advent of being able to fly, they were able to take pictures on the ground. And now DoD uses it for different things, such as being able to identify what is a building versus a cave, or whatever they're trying to identify for attacking. It's also very commonly used in agriculture as a way to say, if you had 1 million acres of land of strawberry fields, you could send a drone up to say, hey, you know, here's in this one particular area, these are some strawberry plants that are dying. I need to go out and give water to them. So it's a way to aid there. And I was thinking about this Corey Schnell, you could use it for criminal justice or Diego. You could even use it to identify areas of gentrification. So new construction for housing, you know, or predict even, you know, migrant populations across a vast desert, for example. So going back to the question at hand, can we use these concepts to help streamline mosquito control? So there's 3 primary mosquitoes that we think of that transmit disease. There's the Anopheles that transmits malaria. There's the Aedes, which transmits Zika or dengue infections. And there's the Culex mosquitoes that will transmit West Nile virus. So we wanted to start off with Culex, the West Nile virus mosquito, because it really likes organic vegetative water. So compared to the other two mosquitoes, it's a little bit easier for us to use these agriculture or environmental indices to analyze. So our primary question, can we use remote sensing to identify and prioritize Culex mosquito breeding habitats? So we partnered with Harris County, which is again Houston, Texas. We partnered with them because they're one of the largest and the oldest vector control agencies in the world. So in comparison to the city of Columbia, for example, they just have way more data that we can analyze. We can analyze going all the way back 75 years if we wanted with data. So in this particular 1 year snapshot that we looked at, we had almost 11,000 different data points that originated from just shy of 1,000 different locations across the city. Each of those red dots indicates a different trapping location. Here's the overall data analysis workflow, which looks really simple, but I assure you it took us quite a long time to do. But essentially, you create your land classification map and your variables or indices. So taking that picture and turning it into data you can use. Then we insert in our mosquito data, so where they were and how many mosquitoes were at that location. Then we extract out what we need, and then we ran two different statistical analyses. One to kind of give us information on what environmental characteristics were associated with mosquitoes. And then the other was a machine learning approach where we employ deep learning techniques to build predictive models. The challenge with that is it doesn't necessarily tell you what variables are associated. It just gives you an output. And the Mosquito Control Agency wanted to know beyond just where the high risk areas were, what environmental factors were associated with it. So we did two different statistical approaches. So let's get started. So to do our land classification, land cover map, so again, taking that pretty picture and then saying, here's the 16 environmental variables of it, we used a UNAT convolution network, which I think Dr. Wang is very familiar with and was fortunate to have one of her doctoral students help us with this. This is a really cutting edge way of doing it. So back in the day when I was training in grad school, we had to do all these calculations by hand. And now it's really just a click of a button. It's pretty impressive. So essentially the computer is training itself to learn how to classify and to do a better job. So each individual pixel that it looks at, it says, okay, your water, your forest, whatever it might be, and then it learns from itself and gets better. Some of the ways that we determine how accurate our model is doing user and producer or even overall Kappa accuracy measurement. So essentially we use site and scene locations. So we'll randomly select 200 or 300 points, and then we'll go out to the physical location and say, yes, the computer was correct. It said at this point, this is a forest, and yes, it is. But then it's not always perfect. For example, we get a lot of times cement. So a paved parking lot of a suburb, often it reflects light similar to a beach. And so it'll get that incorrect. So then we have to go back and we retrain. So as you can see along the very bottom of this, that producer accuracy. So for example, bare land has a 75% accuracy. So we would go back and reanalyze those points to get it to be a little bit better. So keep training. So here is what our pretty picture image comes out to be. So we created 16 different categories of what different environmental conditions we were looking at, ranging anywhere from grassland to wetland to aquatic beds. And then we even within like an urban environment, we created 3 different categories of how dense that urban environment could be. So next we had to pull out the data we want, because even though we're all into big data takes a lot of time and computing resource and effort to do. So what was meaningful for us is we know that Culex mosquitoes typically fly less than 200 meters. They have very small wings, so it's even impressive that they go that far. But what we did was for every mosquito trap location, we created a 200-meter circle buffer around it. As you can see, these little circles indicated here. And then we extracted out the data we wanted. So within that 200-meter buffer, how much of that percentage was water, how much of it, how wet was the soil, for example, and then other factors, weather factors, for example. So looking at the first statistical analysis we did to figure out what environmental characteristics were associated with high abundance of Culex mosquitoes, Again, our primary outcome was how many mosquitoes were at that location, and then what's associated with more mosquitoes. So a variety of different factors went into that. And this is an example of what our data set ended up looking like. So the circle here represents a 200-meter buffer. And within that buffer, we knew it was 20% medium development, which is going to be kind of your suburb type area. It was 75% high developed, which is going to be your downtown urban environment. And then there was 5% open water in the area. So then along the bottom, that's an example of what kind of that large Excel spreadsheet basically looked like. So every row was for any trap for that day, how many mosquitoes did we collect? And then what were all of the associated variables with it? And then we threw all of that into a negative binomial regression. And then we used a backward stepwise model to build our final multivariate model. And in the end, what we found is that areas with healthy vegetation, cultivated land, wetlands, and then even high development were significantly associated with high abundance of mosquitoes. But then areas with large standing water, interestingly, were not associated with mosquitoes and had an opposite effect. And then there at the bottom is our model equation. So then the other aspect of what we wanted to do was to do the employing of a neural network analysis to identify high risk areas that Harris County could go out and screen appropriately for. So we utilized a variety of different machine learning approaches, and we found that K nearest neighbors was the most significantly associated or had the best accuracy. And so here in the end is our output, our deliverable. So we created areas of low, moderate, high, and high risk. And so this is at a very fine-tooth detail. It actually took almost 24 hours to create this map from the time we started it. And that was on a Hyperion computer. So you can appreciate how much computational effort really went into this. I see Susan smiling, she knows. And so this has been given to Harris County, and they're using it now to actually identify new areas to set out their traps. So when we were talking to vector control agencies across the United States, they all pretty much told us the same thing. They set out traps every year in the same location because that's just what they've always been doing. And they are open to putting them in new places, but they don't really know how to do it. And so these types of models and workflows can inform and provide evidence-based to identify new areas for spraying, because the trapping is so important. Where they put the trap, if they get a lot of mosquitoes at that trap, then they'll spray. And so by default, areas where there's no traps going out, they're not spraying in those areas. So you could be getting a high amount of transmission. And then this is just our future directions. We were very fortunate to get an R01 in September for what we're calling the ACT study. So that's looking at Aedes aegypti, which is the one that transmits dengue and Zika, chikungunya as well. And these are associated with very highly dense urban environments. We call them the container mosquitoes. They like to live in your little flower pots or even your bird baths. So please tip and toss. That's what we like to say. Tip that water and toss it out. So that study is going to be focused and starting in Houston as our training model. And then we're actually going to be working in Miami with their local vector control agency to develop more of a validated model. So is it just specific to Houston, or can we create something that's representative across multiple urban environments? And then on the right-hand side, we just got our funding notice. We start in this month, in February. We'll be going into the Brazilian Amazon, looking at malaria. So their recent new president is allowing for large amounts of deforestation in the Brazilian Amazon, and we're seeing a resurgence, unfortunately, of the malaria, mosquito, and associated transmission to people. So we're going to be utilizing drone imaging to identify what are, if we have two similar plots that are both being deforested, what is associated then with resurgence of malaria versus not in the production of those habitats. And with that being said, I'm sure you can appreciate this is a huge effort, and I'm very fortunate to have had a great team to help me, as you can see here, and some great funding. And then I will put my last slide on. Just a reminder, please, if you have students, think about the Health GIS Scholars Program. Applications are due soon. email should be going out. Okay. How is that? Oh, I finished right on time. Perfect. And with that, I will introduce Diego very quickly while you get your screen started. So Diego Leal is an assistant professor of sociology in the College of Arts and Sciences. He earned his PhD in sociology from the University of Massachusetts in 2018, after which he has joined U of SC. He's originally from Bogota, Colombia, where he got his master's and bachelor's. His research applies lenses of computational social science and network science to the study of international migration and minority health. And today he's going to introduce us to the utilization of Twitter data for COVID-19. Take it away.
Thank you very much, Melissa. I'm hoping you can see the presentation and hear me well. So, okay, the presentation is titled Leveraging Social Media Data to Model Risk Perceptions and the Politics of Mask Usage in the United States. This research is in collaboration with Dr. Shan Chao and Shanglong Li, who are also professors here at the University of South Carolina. So the structure of the presentation is very traditional. First, I'm going to talk about the rationale of the research. Then I'm going to introduce the data and methods. I'm going to discuss the results. And then by the end of the presentation, I'm going to be talking about some discussion and conclusion points, very preliminary, by the way. So the rationale, as we know, COVID-19 is a leading cause of death in the United States. And in that context, we also know that the CDC has recommended mask usage as a mitigation strategy to stop the spread of the virus. But we also know that that recommendation to wear a mask has been highly contentious. So there are some groups that really oppose to such recommendation. And basically what we're saying here is that it is worthwhile to understand the correlates of such opinions and why people are thinking the way they are. So in that context, people like Dyer and Culex have been saying that or mentioning the signaling power of Twitter and its potential use as a tool for monitoring public perceptions of risk during large-scale crises like the one that we're living right now. And that's exactly what we're doing here. We're using geotagged Twitter data to estimate perceptions of risk, specifically susceptibility, severity, and negative emotions related to COVID-19, and see how those risk perceptions are related to mask usage in the United States. So how exactly do we do it? So the data and methods, right? So the dependent variable here is county level data aggregated at the county level, right? Survey data published by the New York Times. These data were collected between early July and mid-July 2020. The key question in this data is the following one. How often do you wear a mask in public when you expect to be within 6 feet of another person? Possible answers were never, rarely, sometimes, frequently, and always. So we wanted to measure frequent mask usage. So basically we just counted the proportion of people that answered frequently or always to this question, and we categorize those as people that frequently use masks. So our variable is just simply a proportion going from 0 to 100, where 100 means everyone is reporting using masks frequently. The key predictor here is perceived susceptibility. It's a risk perception index. Data comes from about 300 million geotagged tweets posted by 3.5 million people in the US between January 2020 and November 2020. This is data that come across 1,000 counties in the United States. So the way we operationalize this variable is basically a basic proportion. On the numerator, we have tweeting, basically tweets about COVID-19 and perceptions of susceptibility. And in the denominator, we have tweets about COVID-19. More specifically, in the numerator, we have number of Twitter users who posted tweets with COVID-19 keywords. Those words are coronavirus, COVID-19, COVID-19 with a hyphen, pandemic, epidemic, and virus. So a number of Twitter users who posted tweets with COVID-19 words, and susceptibility keywords. What are the susceptibility keywords? These are listed right there in the slides. You can see words like unsafe, not safe, high risk, hesitate, believe, undoubted, undoubting, immune, immunity, at risk. So that's the numerator, number of Twitter users who posted tweets with COVID-19 keywords and susceptibility keywords. And in the denominator, we just have all Twitter users who posted tweets with COVID-19 keywords. So that gives us a proportion. We multiply that times 100 to get an index that ranges between 0 and 100. In terms of the controls, we control for a host of key demographic variables. We have a control for conservatism, which basically is the proportion or the percentage of votes for Trump in the 2020 election. We have the percentage of people that are 65 years old or older. We have percent people with college level education, average income in a given county, percent poverty, percent unemployed, population density of the county, the percent of each race, Black, Asian, white, and other, percent Latino, percent people with health insurance, and the cumulative number of cases of COVID cases per 1,000 inhabitants in a given county. So all of those are county level controls, and we have a state level control, which is a statewide active mask mandate, because there are some states during the period under analysis here that had an active mask mandate, and of course you expect that states that have such an active mask mandate, the people living in those states are more likely to report using masks. The method is an OLS linear regression given the nature of the dependent variable, which is continuous. Okay, so the results. Some descriptive results first. This is how the dependent variable looks. This is the distribution of the variable. The mean is 79% for percent people reporting frequent mask usage. The range of the variable goes between 31% and 99%, which basically means that there are certain counties in which pretty much everyone was reporting to use masks frequently. And then on the lower end of the variable, we have counties in which only a third of respondents reported using masks frequently. This is how the key predictor looks, the distribution of the susceptibility variable, the risk perception of susceptibility variable. Mean is 11%. It ranges between 2 and 25%. So on the upper end, that means that 25% represents a scenario in which in a given county, 25% of all Twitter users were tweeting about COVID and susceptibility related to COVID. And in the lower end of that variable, 2% means that only 2% of the people that were tweeting about COVID were also tweeting about COVID and their susceptibility related to COVID. And one of the key controls here is percent of people that voted for the Republican Party. So that variable ranges between 5 and 85% of support for Trump, with a mean of 54%. Okay, some more descriptive statistics here. These are correlation metrics. They do not include all the covariates, just key covariates, because including all of them was kind of like too much. But on the upper end here, the first correlation metrics, you see the first column is the correlation between mask usage and key predictors. So there is a negative correlation between mask usage and perceived susceptibility. There is also a negative association between mask usage and percent of people that voted for the Republican Party, and the same for poverty. It's also a negative association. And there is a positive association between mask usage and number of COVID cases, a mask mandate, and percent people with health insurance. And then the correlation metrics at the bottom shows relationships between the key predictor, susceptibility, and the controls. So we have a negative association between perceived susceptibility and the number of COVID cases, and a positive association between susceptibility and number of people, percent of people that are 65 years old or older, and percent people with health insurance. All those correlations were significant at the 0.05 level. So the inferential results, I'm just going to show one table here. I know it's a big table, but I just want you to focus on the first row over here. Basically, what we're seeing here is that the percent frequent mask usage tends to be lower in counties with high perceived susceptibility. So we were scratching our heads, for a minute about this. It didn't make a lot of sense initially, because what you expect is that risk perceptions to be positively associated with the uptake of protective behaviors, right? If you feel like you're at risk you should be protecting yourself. That's kind of like the general logic. So we tried different specifications, different things, and this didn't seem to be an artifact of the modeling strategy. So we try to explain this, and the best explanation that we kind of basically came up with was related to politics. So to explain this, basically what I'm going to show you at the beginning here is results from an interaction term in which we interacted conservatism measure as counties that either saw Trump winning the election or Trump losing the election, so a 1-0 variable, and we interacted that with perceived susceptibility. And then these are the results. You see the numbers over there, but I think that the plot is is easier to understand. So controlling for everything else, if you focus here on the counties in which Trump lost the election, the blue line here, what you see basically is that no matter how susceptibility was, if it was low or high, remember that susceptibility ranges between 2 and 25%. Doesn't matter how low or high susceptibility is, mask usage is pretty much the same across the board. So this slope is actually not different from 0. However, if you look at counties in which Trump won the election, conservative counties, you start to see that the higher the susceptibility is, counties with higher susceptibility, the less people reported using masks frequently. So that was our first clue. Then we did some analysis based on average marginal effects. So basically what you see here is different levels of support for Trump, starting on the top here at only 5% support for Trump, all the way to 85% support for Trump. And what we see is that the average marginal effect of susceptibility is negative when the Republican Party wins a majority of the vote. So only on these scenarios highlighted here with this green square bracket, what you see is that in these specific cases where the Republican Party won the election, is where you see the negative slope. So robustness checks. We were trying to see if these results hold based on other risk perception indices. So we have a second index here, perceived severity. So this index captures how serious people believe health risk, in this case, health risk related with COVID-19, how serious those risks were, and how they thought adverse physical consequences or social consequences were going to be. So keywords for this risk perception index were lethal, fatal, just, shameful, paralyzed, restricted. And basically we see the same kind of association. Only in conservative counties, we see the negative slope. And we have a third risk perception index. This perception index is about negative emotions, which are related to feelings of fear, outrage, and dread. Keywords for that risk perception index were dread, fear, scared, nervous, worse. And we see the same association. So we see consistency there. So after we make sure that we model this in different ways, we got the same results, we have different indices measuring risk perception, we got the same result, we try to explain this out theoretically. So the best explanation that we have so far is this. It's a two-part explanation. So the first part of the explanation basically says that COVID-19 cases negatively affected Trump's vote share. So the work by Vaccination et al. Basically shows this is quasi-experimental work showing that the severity of the pandemic affected Trump's vote. So basically the pandemic was bad news for Trump's re-election. So that's element number one of the explanation. And then element number two of the explanation is what Conway et al. Called the perceived anxiety ideology relationship model, or PAIR model. One of the predictions of this model is that ideological groups who feel a pandemic will affect their own ideological ends will be less likely to signal the severity of that pandemic as a threat. And I think that opens up a way to explain the results, because basically what we're seeing is this. We're seeing that in counties in which risk perceptions were high, basically counties in which people were freaking out about COVID, perceiving as a threat, conservatives in those counties felt, rightfully so, according to Vaccination et al. Evidence, that will affect negatively Trump's chances of being reelected. So given that conservatives in those counties where people were kind of like very concerned about COVID felt that way, they were less likely to signal the severity of the pandemic, as predicted by the PER model. So we know that a key way to predict the severity of the pandemic is by wearing a mask. That's a very powerful way of showing that the pandemic is real and that there are real threats in there. So in that context, you can understand why in those counties conservatives were less likely to report frequent mask usage. And that's basically the end of the story.
Oh, perfect. I was going to say we're at 1:50, so if you want to wrap up.
Yeah, that's pretty much it.
Okay, great. Thank you. Well, as our next speaker comes up, I will go ahead and introduce him. So Corey Schnell is an assistant professor of criminology and criminal justice in the College of Arts and Sciences. Corey received his PhD from Rutgers in 2017 and joined USC shortly after. His research examines the methodology applied to understanding where crimes occur within cities and refining descriptions of the spatial distribution of crime patterns. Today, he is going to talk about his geospatial work on crimes in urban areas. Take it away.
All right, thank you, Melissa. And let me know too if you guys can't hear me. So I'm going to do something a little different and give more of a general overview of some research I conducted that's going to give you a taste for how we use spatial analyses in criminology. So today's talk, I just kind of put in 3 different sections. I'm going to give you in the first section a bit of background, kind of more or less literature review on how criminologists approach the issue of space, specifically pertaining to the distribution of crime. And then I'm going to, in the second section, talk about some of the research I conducted, which is a couple different studies, but they're looking at the same thing, violent crime in Chicago, in kind of a different perspective, and it all fit pretty well together. And then I'll wrap it up with a discussion where I'll kind of drive home the key findings again and talk about some of the limitations, future directions, so on and so forth. Okay, so the background. Generally, in criminology, there's 2 approaches to understanding the relationship between crime and place. The first is called neighborhood effects, or generally that's what the perspective is called. And this one is the oldest. It's been around for about 100 years, where we look at neighborhoods as the unit of analysis and social disorganization for the theory which explains crime variation between places. And the origins of this are in the Chicago School of Sociology, so it's a very interdisciplinary approach. And generally, we measure neighborhoods using census tracts. And I'd still say this is predominantly the main approach to understand crime in place. The second approach is a little more recent. It's called the hotspots perspective, where we look at microplaces as the unit of analysis and criminal opportunities, the kind of main theory to explain crime variation. And this research, for example, microplaces are generally measured as anything within a neighborhood or smaller than a neighborhood, such as the specific address where the incident happened, a street segment, which is the most popular, a street block, again, anything that is sub-neighborhood in terms of spatial units analysis. And criminal opportunity theories use rational choice as opposed to social disorganization, which is a little more rooted in sociological explanations. So these are the kind of 2 big perspectives we take. And there's a lot of really interesting research on crime in place that happens outside of cities, looking at states, countries, and so on and so forth. But it seems like most of our research now is kind of really focused within cities analyses. And there's a couple of reasons for that. One of it is tied to the Chicago School, but for the most part, our research kind of takes place within cities because they're more interesting domain for policy and theory, for us at least. Now, there's been a kind of attempt by contemporary research to reconcile these differences and not necessarily have these 2 perspectives be competing, but have them be complementary. So a lot of people had tried integrating these 2 approaches. And most research really considers the theoretical integration of social disorganization and criminal opportunity. How can you bring these 2 together to have a better explanation of where crimes happen within cities? And this research is very interesting, but my research kind of takes a different perspective and says, well, it's very, important to kind of understand the theoretical explanations, but I think it's first important to start with understanding the spatial distribution and specifically looking at the hierarchical integration of these 2 units of analysis and how by putting them together, you can have a better understanding of essentially where crime happens within cities or descriptions of its spatial variability. So it's very simple research in that sense. It's descriptive, just looking at the distribution, but using this different perspective kind of gives it a power by addressing these very simple measurement issues that we're all, as spatial researchers in different disciplines, all pretty familiar with. But in criminology, we are in some sense a little new to spatial analyses. So we're still kind of working through the very simple things of like, how do we measure where crime happens and what are the kind of costs and implications of that. So the two examples of these problems would be the MAUP, the modifiable aerial unit problem, or this is an aggregation bias, where you look at crime incidents which happen at addresses or very specific places, and then for the sake of policy or theory, you aggregate them up to larger units such as neighborhoods, counties, states, so on and so forth. And what is kind of gained or lost by aggregating from smaller to larger places. And the same is true when you look at the ecological fallacy, or is inference from taking a larger place and kind of disaggregating the places that compose it. And I have an example of that in the next slide, so I won't talk too much about that. But more or less, the research I conduct is focused just on this very simple idea of what is the typo there, the ideal unit of analysis, or what is the ideal frame to understand where crime happens within cities. And it's a loaded question in that sense, because based on these two problems and other spatial analyses, there's not a single correct or proper unit of analysis to use. So me and my colleagues are very big advocates of using multiple spatial units or a hierarchical approach to understanding where crime happens within cities. So now I'll get into some research to kind of just illustrate across these studies in the most kind of simple way why the unit of analysis and the selection of it matters so much to understanding where crime happens. So first here I have a map of Chicago. I have the boundary of Chicago. You can see here it's nested on the shores of Lake Michigan, very beautiful. And it's right on the border between Illinois and Indiana. Here we have a neighborhood measure, which are community areas. They're the largest. This is a macro measure of neighborhoods in Chicago. They're composed of a bunch of different census tracts. So I zoomed in here. Let's go back real quick on two community areas on the south side of Chicago called Inglewood and West Inglewood. And so what we're doing here is to kind of illustrate, in this sense, the ecological fallacy of starting with a larger unit analysis and going to a smaller one. So here we're looking at violent crime incidents in Chicago from 2001 to 2014 in the study. And we're looking at these two neighborhoods on the south side, which in general, Chicago has a reputation for being a very violent city. In particular, the south side of Chicago also has a reputation for being where most of this violence is concentrated. So zoomed in on these two community areas, we see they have high levels or high concentrations of violent crime incidents. We kind of disaggregate to look at neighborhood clusters, which are a meso neighborhood measure, and they're also composed of census tracts. You can see they're nested within these community areas. So when looking at high violent or neighborhoods with high violent crime rates, you see even disaggregating that's not necessarily the best representation of what's happening on the smaller scale. You see neighborhood clusters here have lower, moderate, and some with high levels of crime. So it's not necessarily reflective of, what is happening in those smaller areas by looking at the larger spatial unit of analysis. And you go even lower to a micro measure, which are street segments, the most popular one. So you can see street segments are nested in these neighborhood clusters, which are nested in community areas. And you see even greater variability. In one of the most violent community areas in Chicago, there still are a large number of street segments that have no violent crime at all. And there is a unit-to-unit variability that you gain by looking at these micro places, which is a very, very interesting and different way of approaching where crime happens and understanding where crime happens within cities. The predominant approach is still neighborhoods. And you think about this when you're moving within a city of, is this a good neighborhood or a bad neighborhood? Is it, you think about crime at neighborhoods, but the reality is when you look at the micro places which compose them, crime is often very rare and there's great variability between places in crime rates. So for a follow-up study, we estimated a multi-level model, which takes those three units analysis and more or less partitions or decomposes the spatial variability associated with them. And this kind of gives, and it's a variance component, you can turn it into proportion. This gives you a very simple estimate across these 14 years, looking at violent crime, for a number on your y-axis here, from 0 to 100, essentially, how much of the spatial variability do we kind of understand based on these units of analysis? So what this research says is that microplaces give the largest understanding from about 55 to 65% of the variability. So what this basically means is microplaces are where the action's at, or most variability or differences in crime rates can be observed. So they're telling you the most about where crime happens within cities. And the two neighborhood measures, neighborhood clusters and community areas, a meso and macro measure, still tell you a modest amount about variation, but most of the action is occurring at microplaces. So hotspots in this perspective that, you know, crime is concentrated in a small number of locations and most other places don't have crime, is much more attuned to where crime is actually happening. And it gives you a much more granular, but also in a sense, truer description of where crime is happening. And I believe it's a more optimistic approach to kind of viewing where crime happens within cities. Now, here we have, this is from another study where I kind of zoom in on a couple community areas in Chicago. And this is just looking at robbery at street segments in these community areas for 3 years. And what we see here, we just use a very simple clustering metric, G-star, which you can use in most of your GIS platforms. And it basically just identifies clusters based on the concentration and their spatial proximity. And what we see here in these two community areas, which I label 1 and 2, and they're on different north and south side of Chicago, you see what are generally we would consider a crime hotspot, which are these small pockets of robberies or these small clusters of robberies where, you know, here in community 2, they're only composing about 1 or 2 blocks. And in this first community area, it's a little larger, but for the most part, it's pretty well contained in a certain area. And this visually is kind of how hotspots are represented and is the general understanding of what hotspots are. So this is kind of showing more or less another dimension to that 50 to 60% of the variability, where most neighborhoods don't have a lot of crime and it kind of concentrates in these very small hotspots. It's easy to target resources there. And what's happening there is very unique to these very specific places. So again, I think it's a more optimistic approach. But on the other end, we still saw that about 40% of this variance or the story of where crime happens is told across neighborhoods. So here we see something very different. So we have some neighborhoods or community areas on the west side of Chicago. And the west side is also, in addition to the south side, a particularly violent area of Chicago. And what we see here kind of really spits in the face of our understanding of hotspots, because we see more or less these clusters of robbery across these community areas. These are very large community areas. Chicago's, you know, the 3rd largest city in the United States in terms of population, and its square mileage is also quite large. But we see these huge clusters of hotspots or robbery incidents that are telling us, hey, these are a little larger than what we traditionally consider a hotspot. So these should kind of go by something different. And this is where neighborhoods are starting to give us a better understanding of where crime is happening, is that, you know, the story of what's going on here is much more interesting on the neighborhood level, because crime isn't just kind of contained to these certain pockets in certain parts of these community areas. It's much more widespread. So there's a more generalized risk of being victimized for crime, in this case, robbery, in these areas. So basically, neighborhoods can be recontextualized as a way to understand the clustering or the kind of spread of crime risk within cities. Okay, so I'll wrap it up here in my last minute. Basically, what this research is saying is integration is the way. We shouldn't kind of think of these two perspectives as competing. We should kind of integrate them to have the most general understanding of where crime happens within cities. Microplaces capture a large amount of the variability. So across blocks, you could have a place with a lot of crime next to a place with no crime. But neighborhoods provide a very helpful tool to consider the clustering of these broader, higher order patterns. And hotspots are really important, but we see much larger clusters that kind of tell us something very different, or I call them formations of crime, and that's what we're just publishing on. There are, of course, limitations. This is focused just on spatially, so it's a snapshot. We haven't looked at temporal relations in this study, but more or less our point is kind of advocating for this integration. And by doing this, it gives you a much more helpful approach to crime prevention strategies and informed theory on this topic. And that is the end, I believe, right on time.
That was perfect. That was really interesting, Corey. I've learned so much from you and Diego already. While we go ahead and introduce the next speaker, Brian Love, I would say if you guys prefer, if it's easier to go ahead and answer the questions in the chat after your presentation's over, feel free to do that. I know Diego and Corey, you both have gotten one so far. So Brian Love, as you're loading, Brian Love is an associate professor in the Department of Clinical Pharmacy and Outcome Sciences at the College of Pharmacy. Following completion of his bachelor's degree and doctor of pharmacy degree at USC, he went all the way out to Cincinnati to finish his pharmacy practice residency. And then we're fortunate he came back. He's board certified in pharmacotherapy with added qualifications in infectious diseases. His research interests include pharmacoepidemiology, viral hepatitis, cirrhosis, and other related conditions. And today he will talk about his geospatial work on medication use and dispersion. Take it away, Brian.
Thank you very much for that introduction. And yeah, so today I'm going to talk about, applying GIS to medication use research. And I would say, just as an introduction to this topic, that research in this area is still pretty underdeveloped, and there's lots of room for work in this area. But to add a little bit to the introduction, I wanted to just expound a little bit about me. One is I consider myself a clinician and academic, but most of my experience has been in pharmacies, a variety of different pharmacy types, from hospital to community pharmacy, mail order, and things like that. As mentioned, my research centers on different aspects of medication use. And, I'm particularly interested in GI and hepatic diseases and infectious diseases. I also have a background in epidemiology, and so kind of interconnecting those two disciplines is the term called pharmacoepidemiology. And then, so why would a pharmacist be interested in GIS, I think, is the kind of resounding question. And so I'll explain a little bit about how I got to that. And so in my research, I predominantly use Stata. I know there's some more fancy ways to do graphs and GIS mapping and spatial statistics. And it's a goal of mine to become more versed in those. But for my purposes today, I'm going to share with you my efforts in a project. And these maps were all generated using a command called grmap in Stata. So a little bit about my interest in GIS, I would say, going back, it kind of centers. I remember as a student and as an early clinician seeing figures put out by the CDC on obesity, and it just really struck me how this was an easy way to convey an increasing trend in obesity in the United States. And so that always made quite an impression on me. And then recently we had in my lifetime the largest pandemic, and certainly has had profound effects on our lives in many ways. And so I started at that point. I was able to acquire some data for South Carolina and the nation on COVID, and so I started messing around with that, playing around with that, and generating my own maps and comparing those with the ones that DHIC put out. And so for me, GIS is a new tool in my toolbox. And so using that analogy, there are some tools that have a little bit more use and are used more frequently and have more wear. I would say that GIS for me is still something that I'm still learning and applying to my research. So for today, I wanted to talk about a project that we worked on that was, we were fortunate to have funded through the South Carolina Center for Rural Health and Primary Care. and basically centered on identifying influenza vaccination deserts, what we called deserts. And so just a little bit of background leading up to this. Pharmacies serve as an important healthcare access point, particularly in rural communities. And compared with traditional medical clinic settings, pharmacists are increasingly more accessible. Pharmacies in general have more or longer hours of operation, including holidays and weekends when other settings may be closed. Patients can walk into a pharmacy and without making an appointment, usually talk to a pharmacist about a healthcare concern. And, consistently, pharmacists rank pretty highly in terms of being a trusted healthcare provider. And so as these data show, pharmacists have become an increasingly important provider of vaccination services over time, both across the United States and within South Carolina. And in South Carolina, influenza is one of several vaccines that licensed pharmacists may administer without an authorized prescription as part of a joint protocol approved through the boards of medicine and pharmacy in South Carolina. So just taking a quick peek at some of the numbers relative to influenza that you may or may not be familiar with, but going back to the 2014-2015 season, approximately 22% of patients received a vaccination in a pharmacy setting. And there was more recent numbers that didn't make it into this presentation. I think the number is up to around 26%. In the most recent influenza season spanning 2020 and 2021, the overall coverage of or percentage of people who received a influenza vaccine for adults 18 and above was 47.3. And across, so South Carolina kind of ranks in the middle of all states across the US. The vaccination coverage rates range from about 42% in Idaho, I believe, all the way up to 64% in Rhode Island and sort of the Northeast areas. And so you can see that pharmacies as a collective across the United States, there's a lot of doses that are administered in pharmacies. So approximately 48 million doses are administered in pharmacies compared to 33 million in physician medical offices. So this project, we conceptualized and applied for funding and everything prior to the COVID pandemic, but the aims of this project really, there were several, and this is just one aim of a couple, but there were several sub-aims that I'm gonna kind of walk through and illustrate and apply how we used these methods. So objective one was to identify pharmacies basically across South Carolina. Objective two was to identify influenza rates. And then objective C was to identify areas of need, primarily lower immunization rates, and also to looking at pharmacy assets, although we have very little control of where someone opens a pharmacy. So just in terms of mapping pharmacies across the state, what we did was we obtained information from the Board of Pharmacy on pharmacies with active licenses, and then we cross-referenced that with to get GIS information from a website called RxOpen, which is part of healthcareready.gov, I believe is. It's a governmental sponsored website that's linked, designed to let people know which pharmacies are open when pandemics are declared. And we also used GIS mapping files obtained from the US Census data to do this. So in this graphic that we see, the darker areas equate to a higher density of pharmacies per 100,000 residents. And the yellow dots on this map and subsequent ones represent community pharmacies. So these are only the pharmacies that cater to the public. So this excludes hospital pharmacies and other pharmacies that the public cannot access. You'll notice that in Dr. Bell's talk, if you caught that this morning, she talked about the I-95 corridor and that there's a lot of inequity in those areas and lower healthcare access in those areas. And what I would like to point out is, and it was an observation that this became a little bit more clear after creating these maps, is that there are still pharmacies in these areas which can serve as access points to healthcare. So 1B, to identify vaccination coverage. In this figure, the darker area represents higher influenza vaccination coverage as a percentage of residents in that zip code. And I'm incorrect here. The denominator is not population data from the US Census. I forgot that we were able to get both from PIBA and South Carolina Medicaid, we were able to get the number of residents that had coverage under one of those two insurance policies for those areas. So these are the percentage of patients who have these types of insurance in those areas as the denominator. But you can see the darker areas are higher influence in coverage rates, lighter areas where there are lower rates. And so we looked at 3 different seasons dating from 2017. This represents the most current data that we had access to. Finally, we set out to then define vaccination deserts. And so what we did here was we looked at within South Carolina, the areas by flu season that had the lowest quartile. And if they had a low quartile in that season, we scored them as a 1 and a 0 otherwise. And then we compiled all those quartile scores. And so the areas with the highest quartile scores, so a 3, are represented by the darker areas here. And the darkest areas represent, so we did that for both the public Medicaid patients, as well as patients covered by South Carolina State Health Plan, PIBA data. And so the darkest areas are areas where those two overlap. So I think there were 7 zip codes that we identified as having the highest desert scores. So these data include only Medicaid and state health plans, so that's a big limitation. There are other healthcare claims data available to us. I think one advantage of this approach is that in terms of vaccination rates that's reported through the CDC and the state, it's done through survey methodology with self-reported information. And so this data looks at administrative claims. So if a patient actually received the vaccine and a claim was submitted, then that gets recorded as opposed to relying on patient memory. So there are obviously some areas where, things like health fairs or workplace screenings, other non-healthcare access points where people may receive influenza vaccine. And so obviously we were unable to account for that. And then it would have been nice to include data directly from the vaccine registry. These data were pre-Simon, the newest version of the registry, and information was kind of sporadic and not as robust. So it's possible that these data represent an underestimate of true vaccine coverage within the state, but we feel pretty good about what we accomplished. So I think, just in summary, these data give us a kind of a picture of influenza vaccination for 2017 to 2020 time period in South Carolina from both public and private healthcare insurance providers. We hope to use this to further guide our efforts to improve influenza vaccination via community pharmacies in South Carolina. And I will end with just some acknowledgments. A project like this is not done by just one person. There were several important people who were involved, including our graduate student, Sean, and Dr. Hastings, who is also, I think, on the call. And then, I want to thank our funder, South Carolina Center for Rural and Primary Health Care.
Great. Thank you so much, Dr. Love. Really learned a lot, enjoyed it. And while we're switching, I'll introduce the next speaker. So Dr. Lee is an associate professor of geography at the College of Arts and Sciences. He received his PhD in geography and geoinformation sciences from George Mason University. He's recognized as a breakthrough star at USC in 2020 and is listed as one of the Geospatial World 50 Rising Stars by the Geospatial Media and Communications in 2021. He also has a number of other impressive accomplishments. And today he's going to talk with us on his geospatial work, looking at human mobility and social networking. Dr. Lee.
All right, thank you, Melissa, for the introduction, and thank you everyone for joining this session here. And today I'm going to briefly just give you an introduction about the work that we have been doing using social media data for measuring the human mobility dynamics and also place connectivity, and in the context of the pandemic. See here. So we know that human movement is a driving force, one of the major driving forces that drive the spatial spread of COVID-19. And since it's the infectious diseases, not only COVID-19, but also the flu, the NIH, and other Ebola, this kind of diseases here. So during this kind of outbreak, it's important for us to know how well people are following, for example, this pandemic here, these social distancing orders, and how effective this order is in controlling the spread of the virus. And also, are there disparities in implementing this kind of social distancing orders? If yes, what are driving factors? And there are other questions you can ask here. So to answer these questions, we do need the human movement information. And that's why in the study here, we have been doing, we are looking at how we can leverage the social media big data here to measure, to quantify the human movement at different geographic scales, for example, at the county level, at the state level, and at the, in the country level here. So this work is funded by three grants here. One is from NSF and also NIH, and also the other one is internal grants. It's the team here, the teamwork within the Big Data Health Science Center. All right. So I'm going to show you a graph here to start with the research framework that we are doing here. So I'm going to talk about, we are going to measure the human mobility in a place-based view here. So the place-based view, the place here I'm referring to, it can be a tract, it can be a county or state or country. So that's easy to understand. And then the movement occurs during a time period, like in a day, a week, or even an hour here. So look at this graph here. You think about it, we have two places, place I and place J. And then we are talking about social media, right? Twitter user, for example. And in both places, we have Twitter users, and they are moving around in a city or in a county, in a place, and they are sending some messages, for example, geotag tweets and some other messages. And based on that, we try to first to see whether we can extract which way the population flows, because we know that people are traveling, are moving between places. Like today you are in Richland County, and tomorrow you go to another county, all right, even the same day you are moving, right? So we can try to extract and visualize the population flows from this data. And then we can also try to measure the population, which is the population here. Think about this Twitter user is a sample of the population here. The number of Twitter users in a county during a time period, like a day or a week. And then we can further measure the movement within these places or between the places. Finally, we can try to measure the connectivity among the places, which is like how two counties are connected. All this information here is relevant to the disease spreading, since it's related to human movement here. So we try to measure those in these different ways to come up with, you think about a number, okay, a number, an indicator, an index in each county, and that information can be further built into a predictive model as a predictor and to better improve the prediction accuracy of the virus transmission here. Let's look at the first one. So just give you a brief overview of how this works here. Think about if you are a Twitter user that you have a cell phone, you send out a message today in this time one at location A, at this location, and then the next day you move to another place, you send out another tweet, right? And then the same user here, we can have a trajectory kind of built, like origin destination. We're talking about million Twitter users on a daily basis here. So those are a big number of data set that we have here. And that definitely can help us to create some very interesting map to show the collective movement of the population in a large scale, like in the national level that I'm showing you here. This is the population movement change in the March 2020, which is at the beginning of the pandemic. From, as you can see, the first map is for March 12 to 13. Each line here is population. It's one. We think about one user movement. All right, brightness. The more bright, which means there are more movement among those places. And then the next day here, and then you can see after about 10 days, the brightness is become very dark, which means the population movement has been, decreased a lot, right? That's actually because of policy and the pandemic. We have social distancing order and stay at home, or recommendations, and people start to stay at home and work from home and no school at a time. That can be clearly reflected from this map here. And we did develop an interactive web portal for anyone that was interested in it to interactively look at this map. You can zoom in, zoom out, and just to look at the details of this movement here for about 1 month time period there on a daily basis. So this is only for the visualization, which we look at the information just visually. Okay, we didn't do any spatial statistics yet. So next we want to do more. We want to look at, like, for each day in a county, what about how many Twitter users are there? What's the population using Twitter user as a sample here out there? What's the change over time about the population, Twitter population in a specific county, across the whole US or across the whole world here? So we are going to measure population here. What we did here, we developed a method here to measure the daily number of Twitter users and Twitter visitors, and also residents, which we have a method to distinguish whether a Twitter user is lived in that county or it's just from other county which had a visitor. So we did that, and then we come up with a kind of a Z-score here to show that on each day, what's the number of Twitter users compared to all the days in the same year. See if there are more users, Twitter visitors, for example, in that day, and then the Z-score will be higher. Okay, this kind of normalized way, standardized way to look at the number here. And based on that, we can try to map the Z-score spatially and also temporally here. So this map, I think, if you look at this time here, from August 2019 to August 19, 2017 to here, you can see this is eclipse date. So 2017 total solar eclipse. You can see clearly a green belt here, a blue belt here, right? A green belt, sorry. And this is the reason for this one. I think we all know that. Probably we can guess that it's because on that day there are totals of solar eclipse, and this is the totality parts here. People are going there to see this event. You can even see the dynamics of this visitors change across different counties and different areas. In the national park area, you can see there people started to go there, went there much earlier, like several days before, and they stay there even several days after the event. So you can see this spatial temporal dynamics here. So that's the movement here. And we can, that's the population. Now we can further look at movements, like people from place A and place B, how we can come up with an approach that we can easily extract all this movement information across a large study area. For example, in the county level in the whole US, we come up with an approach to develop a scalable platform for extracting this information here. And then this one is still is online web-based portal. You can click any country, any county, and any here the central tract to look at population mobility changes across the time period. Like this is for 2 years on a daily basis. From all these graphs, we can see that the impact of the COVID-19 on this mobility. There's a big drop here. This is the University of South Carolina area. You can see there a long time, several months, there no movement at all for here, which is there's like the summer in 2019. Here we have much like longer time period without any mobility information. So we developed a platform that's to share this data to the world. Actually, we already have many visitors from 56 countries all across the world, and anyone you can go there to download the data and to integrate that in your own research. So we also use that to study the disparities in social distancing, and then we see that the richer county, the county with higher income, tend to follow the order as well, which people are more likely to stay at home. But the counties with a lower income, they're less likely to stay at home. And this is confirmed by not only looking at Twitter data, but by looking at all the other 3 data sources like Apple, Google, and the cell phone data here. It's consistent finding here. Finally, I think the quick go through about place connectivity. So based on those movements, we can try to measure the connections between different places. The connection is a very important concept here. I think in this like in this pandemic. I mean, if 2 counties, for example, are connected very well, there means there are lots of movement among them, population movement, right? And then if one county is a hotspot in the disease outbreak, and the other county probably likely to get more infection cases. So we define the place connectivity index called PCI as the number of shared Twitter users in the 2 places. Like if you are a user in county A, and then you also add a user in county B, and you are being counted as 1 here. If there are 10 users sharing the same 2 county, and then that 10 user will be here, which is Sij. And then at the bottom is normalization here. And then based on that, we built using like 1.4 billion tweets for 1 year 2019. We built an index between a PCI index between different geographic scales like county level, tract level, and metropolitan area. And we come up with this model here. And this index now has been released to the public. Anyone can use that. And we use that to try to, this is just demonstration about how the index looks like. All right, this is from Japan to all the other countries, how Japan is connected to other countries. And from this, this is another one from Italy, connected to other states, other parts of the world. And this is Chicago, how the Chicago is connected to other counties. And this is a tract level in the Central Park in the New York City, connect to other parts of New York City. So the index is multi-scale, it's also in the global level. And then we look at that, how this can be used as a potential predictor for the COVID-19 here. And then we found that the PCI, by controlling for the distance here, can explain about 25% of the variance of the infection rate at the early stage of the pandemic. We are using New York City to other states as the PCI here in this model here. And also, is for this one, and also PCI not only can be used for the public health, but it can also use for disaster like hurricane evacuation, right? We want to know where people are going, which county people are traveling to during the evacuation order. And then by integrating PCI, we further improve the traditional model to reduce the error by 35%, which means the familiarity of people from one county to another that play a role in people choosing the final destination here. So looking forward, so we are trying to developing a model, a predict model that to better integrate this, population movement information into the SRI, disease, infectious disease infection model here to better predict the future, the infection rate, both spatially and also temporally. And we try to use AI here to facilitate the prediction. And that's it. That's some publication here, and feel free to check out. All right, I think time is just right.
Perfect timing, Dr. Lee. That was really fascinating. I think you could probably work with Schnell on if there's an event like Super Bowl, can you predict where there's going to be, crime that occurs that you could deploy more cops to that location, or even with Diego, the work you're doing, if there's a natural disaster happening in Mexico, can we predict where those people are going to go so we could, deploy aid to medical care. So anyway, it's very fascinating. Thank you.
Thank you. Yeah.
Okay, and as we switch over to our second to last speaker, Dr. Nathaniel Bell is an associate professor in the College of Nursing. He received his PhD from Simon Fraser University, and he has completed a 3-year Canadian Institutes of Health Research postdoc fellowship in trauma outcomes at the University of British Columbia, Department of Surgery. Very impressive. His research program addresses 3 topics: social determinants of health, methodological research on improving access to and outcomes of medical care, and conceptual frameworks to understand how we can improve access to care. So it sounds like you and Dr. Love have a lot in common. And today he is going to talk with us about his geospatial work on racial and ethnic disparities within the healthcare setting. Thank you. Take it away.
Great, thanks. Can everybody see my screen?
Yep, we can see it.
Okay, sorry, it's been a while since I used Zoom, so I can't see you, but I can see my PowerPoint slides. Thanks, Melissa. These are good and great talks. This has been a great day. So I'm going to change it up a little bit. I'm going to kind of follow how Corey did his presentation. I'm just going to give students that are on this call and my colleagues just an overview of how I'm using GIS and spatial methodologies in topics related to racial and health equity, more so than getting into specific papers that they're tied with. So in the 15 minutes that we have, it's short. So if you have questions, please email me. You can see my email on the screen, and I'd be happy to answer any of your questions either today or at a later date. And okay, so am I moving? Did you see my screen move? We're all good? All right. So my focus today is just really broadly, I'm going to touch on some areas of health and racial equities research and advocacy where I think spatial data analysis is applicable. It's in no ways meant to cover all aspects of what these topics mean and their importance, but I will touch on how we can use spatial data analysis techniques to advance this discourse. And I'm just going to do so, not anything I don't think is nearly as substantial as what we've seen so far today, but exciting work nonetheless. And I'll touch on how we can and how I'm using spatial modeling techniques to advance this discourse, and techniques that I'm using that others can replicate. Most of you should all be familiar with the methods that we're applying in this study. And then at the end, I'll talk about where I'm directing this with health policy and health promotion, where the output of where this research is going. So for most of my work that you're going to be hearing about today with health equity, it's really from a quality perspective in terms of healthcare quality, in terms of whether or not we're looking at whether or not the care that's available is equitably distributed, can everybody access it equally. A lot of my work too gets into payment reform and whether or not certain people or providers are unjustly penalized because they don't take into consideration different case mixes. So there's a number of ways to look at equity. I'm going to focus today, hopefully, more so, or not hopefully, actually, more so on the equity side of looking at equitable access to care, and also and racial equity in terms of outcome indicators that are used for quality monitoring. But regardless, all of it is important because, especially in America, where this emphasis and this need to have this spatial lens and a lot of this research that we do in health services research, just because of things that we have to contend with in this country in terms of like the legacy of redlining and what does that mean for the effect of, how resources have been distributed across neighborhoods, where primary care providers elect to practice, where you get into white flight, you get into proximity to point source solutions, and you can go on and on and on. So the emphasis and this need to have this spatial lens when looking at, health services access, whether everything's equitably distributed and whether or not outcomes are equitable, having that spatial lens is really important. And I think in the most part, most people do know that, but not everywhere. And in some of the health policy meetings that I sit on, GIS is still new, the spatial data is still new, the linkages are still new. In other cases, they're all well ingrained. So we're all doing great work, and it's good motivation to keep on with what we're doing. So this first example that I want to touch base on is just how we're using spatial data techniques to look at where specific primary care models, in this case patient-centered medical homes, where they're opening up and coming online across the country, and whether or not that's corresponding with, for lack of a better word, where the high need areas are, where that emphasis on prevention is going to be most necessary. And one of the impetuses for this is because many policy makers, rightly or wrongly believe that historically marginalized populations have the highest ceiling when it comes to these advanced models of primary care, given that they have the most amount of room for improvement for whatever reason that might be. And briefly, these medical homes are, they're essentially, it's a group of primary care practices that are going to get reimbursed on top of what they may have already been getting reimbursed for. So they're going to get an additional headcount remuneration because they're instituting things like EMR. They've got case managers that are following up with patients. They're supposed to be providing patient-centered, culturally centered care. And all of these are supposed to reduce costs, unnecessary spending. They're supposed to improve patient and provider confidence and satisfaction with care, and so on. But there hasn't been a lot of work to date on whether or not all of these high-end practices are they going where they're most needed, where are they going, who has access to them, and are they tackling issues related to racial and health equity, which by and large many people think that they are able to do because of the way that they've been designed. So this first study we took, very simply, we just wanted to look at, all right, where's the distribution of medical homes throughout the country versus where's the distribution of outcome indicators where we would likely think that they're going to be most needed. And so we just use methods of LISA to look at high and low and mixed areas of clusters of where medical homes were most prevalent. And then we overlap that with areas where we're having high disease rates, high need rates, and we're using Robert Wood Johnson Foundation community health ranking indicators to do that. And then very simply, it's just almost like an overlapping polygon issue where we're taking we're looking where those high and high clusters overlap, where you get a high and low cluster overlapping. So we can come up with these favorable, unfavorable, high need, low need, different realities based on the community health rankings and the distributions of the medical homes. And these are just a series of maps that we were generated that went along with the project. But at the end of the day, what we're working with essentially are, probability estimates of what's the likelihood that you're going to live in this, low need or high need or unfavorable cluster, and looking at a number of different indicators that were associated with that we were able to do because we were using this overlapping circle techniques using the LISA method. And this example here from this output of data is just showing you that, when a county rate is about 20% uninsured, the likelihood of residing in an unfavorable geographic cluster, so that's going to be a high need for medical homes, but a low availability of medical homes, rises, exponentially compared to how insurance rates are related to these other different overlapping clusters that we're seeing. That's it in the nutshell. That's what we're walking away with this one study of just intersecting the LISA methods with the community health rankings, and then looking at medical home distributions that way. You know, another way that I was integrating GIS into similar questions is looking at proximity to providers versus proximity to hospitals. So one of the big emphasis on medical home research is whether or not they're curbing unnecessary costs, avoidable and potentially avoidable emergency admissions to the hospital are one huge cost. And so one of the issues is that when people are evaluating whether or not medical homes are able to curb these types of things, they're not looking at where a person lives relative to their primary care provider versus where they live relative to the hospital. And so what I was interested in looking at is whether or not there's this distance decay effect with medical home quality indicators, whereas you know, if you have person A and person B, and one person's in medical home and one person's not, you'd expect if they live a mile away from their primary care provider that the medical home is going to have a better outcome because they're designed to have better outcomes. But my hypothesis was that once you put those two people like 30 miles away from their providers, that I would expect the outcomes between those two clinics to be identical because of the decay mechanism that's going to come in place, where it's just like, okay, maybe the hospital is going to be a more viable solution. And so we're using, you know, traditional epi models of just using some GEE models, and we're adjusting for things like age, comorbidities. We're looking at time of day, whether it's a weekend visit, and so on and so forth. But what we wanted to look at was this emphasis on, you know, this proximity, relative proximity, if you will, to providers. And so again, here's an output in Stata. Where you know, it's not a great signal, but there was a signal where we're looking at, so persons that are enrolled and obtain their care from a medical home, when their proximity to their primary care provider was greater than it was to the hospital, they're less likely to have an emergency department admission. But as that proximity to the hospital became greater than their proximity to the primary care provider, their risk of an unavoidable incident was just the same or greater as it was for somebody who is going to quote unquote standard primary care practices. And so we were doing this for a list of known diseases and comorbid causes. So again, the emphasis is that just introducing that spatial mechanism of looking at drive times, network analysis, those types of models, integrating those into quality performance assessments, that we can see it's like, okay, where, you know, where the distribution of these services are and how that relative distribution matters when it comes time to looking at performance measures. And this, in third example, it's more of the same, but in this case, we're looking at relative proximity in relation to the primary care models, and then looking at racial disparities in outcomes that these different providers are able to generate. And the impetus for this work comes out with changes that are being made by the National Committee for Quality Assurance, NCQA, which is the largest designator of medical homes throughout the country, where they're modifying their risk adjustment criteria to look at things like race, ethnicity, socioeconomic status. But missing in this is an emphasis on geography itself and proximity to care and those types of things. And so, and at the same time, there's also this emphasis on stratifying their risk or performance measures rather than adjusting for them. And that's a whole other conversation. But what we're arguing is that risk adjustment is much preferable, especially from a racial equity lens, than simply stratifying analyses by these indicators. So we were expanding on the method I just showed you in the second example, and this time introducing the Institute of Medicine's definition for racial disparities, but including in that disparity model the proximity to providers under the rationale that where one lives and where health services are located are inherently tied to segregation and policies in this country that have created inequities within neighborhoods. And so all we're doing is building on top of the IOM definition, adding in the spatial component, and then rerunning the analysis that you just saw in that last analysis. Briefly, to like replicate the IOM model, essentially what you're doing is you're building, in this case, we did a generalized estimating equation model for each dependent variable we're looking at. In this case, was avoidable admissions. Then what you do is you run the model, then you get your predictive, then you swap out your health status variables that you need to change in order to replicate the IOM model. In this case, we're also including proximity to providers as part of that disparity. You're getting new predictions based on the IOM definitions of what you need to swap out, and then you average everything together, you subtract the predicted probabilities by race, etc. Essentially, you're getting an average marginal effect in the end. And the result is essentially akin to like a difference in difference model, where we can look at, you know, outcomes achieved by patients who are going to medical homes, those who are not going to medical homes, and looking at the probability that they're going to have an avoidable admission after accounting for neighborhood socioeconomic factors, proximity to care, and following the IOM guidelines. And what we're finding by and large is that, you know, medical homes are able to curb a lot of these racial disparities in health that policymakers are really hoping that they can. And it's thought that, you know, by doing the case management, having more attention to social determinants of health, that they're able to do so. And so the results are encouraging, and from the standpoint, in all these examples, we're using state Medicaid data, that they're able to make those jumps and they're able to make those improvements for sure. So for the policy implications for a lot of this, most of my work's all with state Medicaid, you know, and the application here could be on network adequacy standards. I mean, there's standards for minimal distances to care. I'm arguing in some cases that they need to be different for patient-centered medical homes, and for agencies like the National Committee for Quality Assurance to, you know, improve their risk-adjusted mechanisms and formula to have a greater lens for health equity. Otherwise, what I think is going to happen is you're going to get providers that are going to cherry pick patients just to improve their scores. This is, you know, a lot of information. So please email me if you have any question. And thank you to my collaborators, Ana Lopez de Fide, Bo Kai, and John Brooks, all from here at USC, and funding for this from AHRQ. So thanks again, and I really appreciate the opportunity to be here.
Thank you. That was excellent, Nathan. And I will introduce our last speaker. And just a reminder to the speakers, if you guys would like to go and answer some of the questions that have come in to the chart, into the chat box, please feel free to do that. Otherwise, we can wait till the end. And so our next presenter and last presenter is Dr. Susan Wei. She's a professor of geography in the College of Arts and Sciences. She's actually received 2 PhDs, one in geography from Michigan State University and one in photogrammetry and remote sensing from the Chinese Academy of Sciences. She's a subject matter expert certified in remote sensing and image analysis, and a co-director for the GeoInt certificate program at South Carolina, and the director of the International Center of Excellence on Big Earth Data for COAST. Her talk today will cover the geospatial work on satellite time series analysis and bioenvironmental change.
Thank you, Melissa. So you could see my full screen here, right? Yes?
Yes, ma'am, we can see it.
Okay, great. So I really appreciate to be part of this session today. Just learn so much about the broad topic and research and usage of GIS. It's so interdisciplinary. And also, Melissa, thank you for your introduction. And I'm glad to follow up your remote sensing talk and move on to, again, this remote sensing topic here. And just dragging all the people here from social studies and back to the images again. So hopefully it's a fun story here. Today I'm going to share a piece of work that my PhD student Xiao Huang and we did a couple of years ago, and expanding the Earth observations from satellites to population. So Xiao really did a great job and graduated 2 years ago, and right now is assistant professor and very active young scholar at University of Arkansas. So talking about, talking about population, please let me bring up this big question: where are people living? So probably almost all the talks ahead is about people, about how the human behaviors are related patterns like there. And so knowing where people live at the local scale or micro scale is quite essential for really a big number of studies, including, for example, what we have talked here, the public service, the urban health, and also social resilience. Population data, we always have them. I mean, the most famous one, probably ready to go one, is the US Census records from different levels like tract, block groups, and blocks. But those data are, I would say, is partially spatial, since those are the surveys from kind of aggregation from irregular boundaries, as you can tell, from county level to the tract level and to the block group level, finally to the block level there. So it's not really telling the much details where people live in this very local environment. On the other hand, here, the remote sensing is play a role. So fine resolution satellite observations, I think we're all kind of familiar with all these base maps already. So we use them for navigation every day, and the ArcGIS has the base map, Google Earth has the global base map there. With fine resolution, like meter scale, we could easily extract the building footprint, like this one I copied from Microsoft Bing team. Individual buildings, building footprints can be easily extracted. But for global satellite observations at such a fine scale, both data scale storage and computation is big, since we are in this big data conference. So in the big data era, advanced geospatial technologies make it possible to enhance machine learning, deep learning, and AI to make this building footprint extraction possible. And also big Earth data allows integrated observation. So expanding from the physical observation, what's going on, what is there on Earth's surface, and to this more social sector. So where are people, like that? So today I'm going to present a quick and short story about how do we integrate them together and extract a population grid. I use 100-meter grid as example, but apparently, I mean, with technology, we can do any kind of finer grid population data set. So this study employs census records to gather population data in the unit of census blocks and block groups. I also directly used the Microsoft Bing building footprint dataset to reflect the building footprint and land use pattern there. So instead of doing that myself, there's already such product ready to use. And also there's another very nice piece of information, Openstreetmap, and they released the land use data set. So all these are open data, so make it more feasible or more meaningful in this big data time. And the census data, not much to mention. The one I use is the 5-year ISMIS, the ACS, American Community Survey data set. So it represents a 5-year average from 2013 to 17. So you can tell so much number of the block groups, they're available over the CONUS. I only tested the 48 United States, the states here, okay, including DC. Another data set, the Bing build footprints, as I said, is already there, ready to download. So Schnell made these great efforts to access the data and to clean the data for this study. So the data set is AI trained and is open source. It's the CNTK, open source Microsoft Cognitive Toolkit, and heavily trained by ground truth, received all this huge number of building footprints all over the 48 states and plus DC. So with all these kind of details there, I do not mean to talk too much. Openstreetmap is the uniqueness for this database is the crowdsourcing. So it's an international effort, and the purpose is to extract and self-updating the land use polygons all over the globe. So again, for the CONUS, we extracted this number of polygons. The purpose for this data set for this study is the residential. So we used its residential area to represent that's the dwelling units, so people live in, and other either natural lands or the built-up lands. Since they are not residential, we kind of remove that so that we reduce the errors when try to get this population grade. And how did we do? It's basically 2 steps. The first one is comparing the Bing building footprints and also the OSM land use, and removing all the footprints that's not residential. So seems quite time consuming, a big computation for this large area, but the technology behind is quite simple. So just trimming to clear up the data. The next step is population disaggregation. It's basically an old technique of asymmetric mapping. So we have this irregular census block group boundary here, and by assigning the weight or and other kind of calculation there, we extract this regularly graded population data. So here, this one is more of the calculation. The story behind, so assume this one is census block and made of this multiple census block group, made of multiple blocks here. And by convention, when we get the population data from census records, we had to assume and people, they are living in this block or block group homogeneously. However, there's never homogeneous living. So there's also always some people live together in this neighborhood, and some live in an isolated area and some other neighborhoods there. So we can tell people dwelling is heterogeneous. So they turn to follow a unique pattern that is not recorded in the census data. So what we try to do is break up the block group using this regular 100 by 100 meter grid, and within each grid, we perform this asymmetric mapping and assigning this partition of the mapping to sorry about that, to the whole grid over there. So let me move on the results. This one is kind of before the trimming. So all the population, they're living everywhere, including this commercial and retail area. That was actually wrong. So after trimming and all this erroneous people living there removed, and they are filled into the residential area. Here is the 100 meter population grade. So just the final output, you can zoom into different cities and tell how people, they are distributed within a 100 by 100 meter grid, ranging from 0 in the remote area to almost 10,000 in the very dense urban area like NYC. So here's the general kind of accuracy assessment. It looks is fitting one-to-one line quite well, except probably this NY, this New York State. And further checking into the details, we found that New York City especially is highly affected by these high-rise dwelling units. So that probably is the next step need to be answered. So the summary over here, I revisit the big question, where are people living? So within 100-meter grid, so we refined people and let them fill in this grid area. And the approach here and also the products here is self-adaptive. So it's kind of, we can change the grid, we can change the unit, and that is high resolution and also some other pros of open data. And especially, I actually highly value the crowdsourcing. The cons, the disadvantage of the approach so far. So as we all kind of having the question marks in mind, the volunteer geographic information or crowdsourcing, its validity, its uncertainty, that's never stopped debating. So it's always there. And also, we just mentioned, what if there is a vertical dimension? So how do we make it better? And those are the future work that with big Earth data, we can do more. So we can further integrate Earth observations from satellite remote sensing data and merge it into the social data, merge it into other data sets and make it more useful, and not only to remote sensing people, not only to geography, but all kinds of studies utilizing this kind of information, so like a population. That's it. Thank you. And I also thank Dr. Lee and his student contributing to this paper published last year. Thanks. It's a good time.
It's perfect timing. Thank you, Susan. Well, thank you. That was, I think, a really incredible series. I know I learned a lot. I'm sure our colleagues and hopefully those in the audience did as well. Hayden, I'm not sure if you could take a second. Hayden is our trustee assistant today. If you could look and see if there's any questions in the chat bot that have not been, or chat box that have not been answered. In the interim, I have a couple questions for you guys to kick it off, unless there's anyone else in the audience that has questions.
Looking through our chat briefly, it looks like every question has been answered up to this point.
Okay, great. So Diego, 300 million geotag tweets. Sounds like a lot of big data. Wow. What are some learning experiences you had or advice you would give to someone that's starting out using Twitter data for the first time?
Yeah, that's a lot of data. That actually, well, so the data, I started using it because I'm part of R25 fellowship through the Big Data Health Science Center. So the data was originally collected by Dr. Schnell Lee here. And I guess, you know, my first piece of advice would be make sure that you have strong networks, which is what the fellowship is supposed to do, right? So they connected me to Dr. Lee, and then because, you know, in that context, I was able to tell them what was my idea, what kind of research I wanted to do, and then they were able to provide the data for me to analyze. So it's really all about that. You know, in this moment, as you saw in papers that people were mentioning, these teams are big teams. There is no one person that is able to do all these different things at the same time. No way. So my advice would be just literally, you know, get yourself out there, apply for fellowships, make sure to connect with other colleagues, peers and seniors, and from there you should be able to explore all these you know, amazing data sets that are able to, you know, and if you use them well, you're able to answer really interesting questions.
Thank you. I think that's a great answer. So my next question is for Corey, Dr. Schnell. When looking at neighborhoods, what would be your ideal microplace? Could you would you want to look at just individual homes or individual businesses? And what is the trade-off between being, a really fine resolution, but then, the amount of analysis or benefit of that?
Oh, absolutely. That's a great question, Melissa, because that's the thing we're kind of struggling with. So we want to kind of have or at least the stuff we're doing, like have a micro place that captures people's lived experiences with navigating an area. So that's one of the reasons why criminologists keep coming back to street segments, because, addresses are too precise. We got to worry about how the data was measured, because our data is usually from like police incident reports. But street segments are pretty true to how you navigate cities in terms of like, you're walking. So obviously we want a unit that is tied into the street grid so you can walk it, drive it. So on that basic level, but also too, if you're living in a place, your kind of interaction is most with your immediate proximate people around you. So we kind of settle with street segments because of those factors, and they're a little large enough where you can not worry as much about aggregating stuff up. But it's a tough question, and there is no right answer. And in blocks, some people prefer blocks, some people prefer addresses. So it's kind of just be open to it and kind of tailor it to what your research is interested in. In this study, street segments fit best, but in other research, other microplaces or other neighborhoods might kind of fit your question better.
Great, interesting to know. So my next question is for Dr. Love. I learned something new today. I didn't know that you could use Stata to do GIS, and I was trained to do Stata, which is really interesting. So I was wondering if you could expand a little bit more about how you came to learn that Stata does GIS. Are there any other tools that you use within Stata for that?
Yeah, thanks for the question. Really, I kind of stumbled upon it myself. And, when I was first getting into more into research, I had a colleague in Dr. James Harden in the School of Public Health, and he's a Stata expert. And so I kind of learned a lot by watching him. But in terms of GRMap, I think it's a derivation of a couple of other user-written programs, and it's kind of evolved over time to be what it is. But I was introduced and I learned about it through, the COVID-19 pandemic, and Stata has a good web presence, and they post webinars and free webinars a lot, and blog posts and things like that. And they had a series of blog posts that kind of walk through using the mapping techniques for COVID-19, and so I kind of applied that to the research that we did here. One of the things that's always attracted me to Stata is that the user manual is very easy to understand compared to some other software packages, and so it's easy to kind of look at the syntax for how to do something and then kind of directly apply that to any work that you might be interested in.
Thank you. Good to know. I will have to look up some of those blog posts. Sorry. So next question is for Dr. Bell. So proximity analysis, it's a really interesting tool. Did you use that in Stata as well? Because I noticed you had some Stata figures, or how did you perform your proximity analysis?
Nope, everything, thanks, Melissa. Everything was done in ARC through SQL Server, and then the output is just put into, it's actually multiple software, because I do all my data cleaning in SAS, because I just find it easier to use than Stata for joining and linking, and then you can use SQL to do all of that. So all of the analysis starts off in SAS with all of the claims data, then that's outputted to ARC to run the network analysis, and then the network analysis is then generated back into SAS to do the linkages, and then the analysis is done in Stata because it's a lot easier to do marginal effects and probability model in Stata than it is in SAS. So yeah, it's all three.
I keep hearing that about SAS, but it doesn't seem as user-friendly as,
It's
Dr. Love said
Stata for so long, so it's user-friendly only because I've been using it for so long. If I had to start all over, I'd probably do R, so you can just go right into Python.
Well,
But
for
I'm
those
like
training
45. I don't know if I want to do it all over again.
Fair enough. The Research Computing Core does offer free introduction to R classes for those that are interested. So we have time
that
for,
would be fun.
we have time for one more question. I don't know if there's anyone else that wants to ask one. Otherwise, between Dr. Wang and Dr. Lee, do either of you feel strongly about answering a question? How about Dr. Wang? So your work is clearly very methodological and very important to make sure that we can get accurate, information and data. I really particularly interested in kind of the high-rise data and how you would analyze that. So what are some of broader applications you can envision for your work? So how would you then, with this information, could you use it for answering, questions along the coast or any of the other work that you do?
Yeah, one direction, I'm just starting a new project is about the historical land use. So historical coastal development, how people they are settling in along the coast and how the land has been used. I think that information is useful to quite a few studies, not only the environmental research, but more like environmental studies and conservation and coastal resilience. I feel when people in other areas, when they do their research, they kind of not randomly, but doing their best to find the most popular data, then that's it. But I think GIS science can do more. I mean, probably the data is not there yet, but with these collaborative efforts, we can know what we can do. I mean, what we can move toward and to contribute more data, better data to exactly fit in the specific research. So I feel these kind of connective and collective thinking is very important for data analysis and data usage.
I couldn't agree more. Well, thank you to all of our speakers today, and thank you for our audience. There's going to be a 15-minute break, and then they will be back at 3:30. Hope to see you then for another round of breakout sessions. Thank you all.